every aspect of it, students, will be a question for you. In the theory, you may be asked about the definition. You are supposed to know the indications. Again, the indications would be very frequently asked in the Viva OC. And whenever you get a case discussion, you may have to discuss about cesarean section. So every aspect of assessment, whether it is the theoretical assessment, skill assessment, or knowledge assessment, you have to know every aspect of cesarean section. It is mandatory. So you should be very carefully listening to this whole session. Delivering the baby after 28 weeks of gestation through an abdominal route from an intact uterus. So here you are supposed to understand three aspects. One is you are delivering the baby from the abdominal route. Second thing is it is after 28 weeks of gestation. This 28 weeks is taken as the period of viability. So sometimes nowadays even little earlier, if the baby is salvageable, you can still call it cesarean, but for definition, theory, practical purposes, you have to remember this 28 weeks as the cutoff. And finally, it should be from an intact uterus. So this is very important to remember that you are cutting the uterus and delivering the baby. There are situations in which the uterus is ruptured and baby is in the abdominal cavity. And if you deliver such a baby, it is not cesarean section, it is laparotomy. You are opening the abdomen, then delivering the baby. Only if you cut the uterus, it becomes cesarean section. Almost for the past 50 years, we are really seeing a enormous increase in the rate of cesarean. Before that, it was not that frequently done. If you just go through the history, a few centuries ago, you know, cesarean was most often done as the last resort. Women in labor for prolonged period is not in hours, it is in days, sometimes weeks, and she fails to deliver, and in this bargain the mother becomes distressed. She may go to the verge of death. So a dying mother or a dead mother, if they wanted to remove the baby, many a times intact live baby to be delivered, this was the last resort to be followed. Even the technique of cesarean was not that evolved, and the mortality rate post cesarean was very, very high, to the tune of 80 to 90%. You know what brought these changes? Anesthesia, blood transfusion facility, and use of antibiotics. These three things have made enormous difference in this particular aspect of delivery route. So the anesthetist and the transfusion person and the availability of antibiotics, which really saw a surge after the Second World War. So 1950 onwards, there is a slight increase in the operative delivery, that is cesarean delivery, and nowadays all of us know that it has increased enormously. And though the healthy cesarean rate for a given population, you know, we keep talking about labor as physiological process. So a physiological process, why should you cut and deliver? She has to deliver naturally. So that is why WHO has given, for any given population, in that population, the cesarean delivery rate should not be above 15%, should not be below 5% also. So it should be around 5 to 15%. That means if there are 100 pregnant women in a given population, then out of that, around 15, up to 15 ladies ending with cesarean section is acceptable. If it goes beyond, it is most likely that unnecessary cesarean section is being done. If it is less than 5, you have to look whether the facilities in that population is adequate enough to conduct cesarean delivery or not. Probably they are going elsewhere and getting the cesarean section done. So it questions the efficiency of cesarean, rather healthcare delivery system for a given population. So this is one thing everyone should understand. But don't extrapolate this information to a tertiary care center or a referral hospital, because in a referral hospital the population that is catered would be from different parts. So it would be from one village, two villages, five villages, for a big city, a metropole city which has the population from various places. So it doesn't represent a single population group. That is why the cesarean section rate could be 30%, 35%. Most of the cases referred for cesarean, so it could be even 50% in some of the hospitals. So we are not talking about that. We are talking about a given population and what is the cesarean rate acceptable, right? Cesarean means to cut. Sectioning also means to cut. You know, you have used double words which mean the same thing. You know, in English literature, this kind of figure of speech is called tautology. Cesarean section is the best example for a tautology. So what are the types of cesarean section? One is classical, other is lower segment. The third one, which many a times in emergency situations we do, is called cesarean hysterectomy. And finally, some historical interest about extraperitoneal cesarean section. So these are the varieties that we talk about, of which the commonest one would be your lower segment cesarean section, and probably the next frequent one would be cesarean hysterectomy, and very rarely you are performing classical, and extraperitoneal almost nil. So if this is the uterus with the tubes and the cervix here, okay, so this part is the lower segment, this part is the upper segment, and in the upper segment most often a midline vertical incision placement is called classical cesarean section. You know students, the moment you open the abdomen, the part of the uterus that you see would be the upper segment, and when the cesarean section was evolving in the beginning, the moment you see the uterus, you start cutting it. So that is how it is a classical one, the old one, the one which was practiced from ancient times. So cutting the uterus in the midline is called classical cesarean section. That is in the upper segment. It is also called upper segment cesarean section. Later on, it was realized that if you open the uterus from the lower segment, all the outcomes, the healing, the repair is, everything is comfortable. So there is a fold of peritoneum here. If this is the uterus, this is the bladder, the peritoneum runs between the bladder and the uterus. So this is the uterus, students, and this is the bladder with urethra. So the peritoneum, which covers the uterus all round, forms a fold here and then runs on the bladder and becomes the parietal peritoneum later. So this fold of peritoneum is called UV fold, utero-vesical fold of peritoneum, and if this is cut, you will reach this portion of the uterus. This is the upper part of the uterus, and this is the lower segment of the uterus, and to reach the lower segment you have to cut the UV fold. Once you cut the UV fold, you will reach the lower segment, and you can put a transverse incision, which is the commonest incision that we place. It is called Kerr's incision. You can put a vertical incision in the lower segment. It is called Krönig's incision. You can put a J-shaped incision here with slight extension to the upper segment. If there is a threat of this incision going on to the lateral wall, you just make a curve here, it extends upwards. So this is called J-shaped incision. Of all these incisions, the commonly used incision is the transverse incision, that is called Kerr's incision, named after Munro Kerr. So this is Kerr's incision. What are the indications? So indications are classified by various factors. One indication classification could be emergency and elective. So emergency cesarean means the woman has gone into labor and after going into labor, some complications set in. You have to quickly take her to the operation theater and do the cesarean section. Most common. Sometimes emergency also could be because of the fetal condition. So the baby is not doing well and quick delivery is going to save the baby. For example, the Doppler changes in the ductus venosus, which you will understand when you listen to the session on antepartum fetal surveillance. Okay, so the ductus venosus flow abnormalities in the baby is an emergency to deliver the baby immediately. She is not in labor, but you are seeing that the baby is not good. That also becomes an emergency indication. Elective is, it's a well-planned surgery. For example, you have a case of previous 2 cesarean sections, previous 2 scars on the uterus. Most often we go for a cesarean delivery only. So we plan tomorrow morning 8 o'clock I am doing a cesarean section. You prepare the patient and everything is arranged. Even if required, a bottle of blood is ready, a senior obstetrician is ready. So everything is prepared. So this is called elective cesarean section done electively, and you are supposed to know the differences and to some extent the advantages and disadvantages of each. In elective cesarean, the patient is very well prepared. For example, if she is anemic, you have given blood and prepared her. If there was any evidence of, say, cough, cold, something, you would have treated her and optimized her condition to face the surgery. Whereas in emergency cesarean section, you don't have time to do all those things. With the associated morbidity, you may have to go ahead with cesarean section. So second thing is correction of comorbidity. As I told you, maybe hypertension, diabetes, everything could be corrected in case of elective and then taken, whereas in emergency you don't have time to do these things and you may have to take them as it is and manage the problems associated with that. Then about your equipment in the sense, are you well equipped to face any of the emergencies with blood, help of a senior, arranging an intensive care unit bed, etc. All are possible in elective, but in emergency may or may not. The presence or absence of a senior depends on the timing of surgery and how quickly you are supposed to do. For example, there is a cord prolapse. You have to do the surgery in the next 15 to 30 minutes. To arrange for blood, it may be impossible. But if there is any kind of, say, previous 1 cesarean section with meconium, or say the previous cesarean section wherein there is maternal tachycardia, you are worried whether the scar is intact or not, in that you can arrange blood in half an hour to 1 hour, then take her up for surgery, monitoring her in between. So there could be some time or there may not be some time to arrange these things or make the senior person available. Post-operative recovery, for all these obvious reasons, is very good in case of elective, whereas post-operative period totally could be stormy because of infection, hypertension, uncontrolled diabetes, bleeding, non-availability of blood. All those things could probably make the situation little grim in case of emergency cesarean section. And in the emergency cesarean section, the lower segment will be thick, so cutting the lower segment may be little difficult and it might bleed more. But when the woman goes into labor, the lower segment, because of the pushing pressure from the upper segment, goes on expanding and the thickness becomes lesser and lesser and becomes very thin. So cutting and delivering and suturing also is more comfortable in emergency. Bleeding also would be less because of the thin lower segment, whereas here it would be little difficult, right? Per-operative bleeding, usually if both are comparable, no comorbidity, no anemia, everything else is fine, in such cases emergencies bleed less compared to elective because of the thinness and thickness of the lower segment. And healing of the scar, thick segments, when they are separated, when you try to suture them, the thick segments, when you suture them, there is a possibility that some gap is there in between, and this gap, there would be collection of blood. This blood totally gets absorbed and some fibrotic tissue may form there during healing, and this causes some kind of fibrotic healing along the incision line. Whereas in elective, rather in emergency, because of the thinness, the approximation becomes very good and healing, unless there is infection. If there is infection, healing is affected. If there is no infection, healing is supposed to be better with emergency cesarean section. So amongst them, you have to pick up what is the advantage and what are the disadvantages of one over the other.